Alrighty, good afternoon. My name is Jack Amato, and today I'll be proposing my capstone proposal defense on supporting occupation-centered practice through the development of an OT-based kinesiotape toolkit within cardiothoracic acute care. My faculty mentor is Dr. Jonathan Lagarte, and my site mentor is pending. So, for the background within postoperative pain and cardiothoracic acute care, cardiothoracic surgery is a common procedure and that is performed in postoperative pain. It limits functional recovery and activities of daily living participation. Additionally, inadequate early pain management does link to poor functional outcomes, underlining the need for effective non-pharmacological pain management. So the overview of my proposed project is that I do want to develop an OT-based kinesiotape toolkit for OT clinicians working in cardiothoracic acute care to increase their self-perceived self-efficacy related to KT application. The significance of my capstone project to occupational therapy is that occupational therapy does play a significant role within functional recovery and discharge readiness through the development of interventions to promote health, well-being, and participation. So within the context of kinesiotape is used as a preparatory method / task to help support interventions to further promote health, well-being, and participation, thus leading to functional recovery and discharge readiness. For the literature review, I did come across two themes. The first theme is the use of kinesiotape and postoperative functional recovery. KT has demonstrated reductions in postoperative pain across a diverse amount of surgical populations. Additionally, KT application is associated with improvements of functional participation and activity tolerance following a surgery. The second theme that I did come across was the use of educational toolkits and perceived self-efficacy within clinical practice. Richards and colleagues did state that structured educational toolkits did improve clinician adherence and practice consistency. Within this study, they did develop a toolkit for clinicians to use that did comprise of 25 standardized assessments for individuals with stroke, and the clinician adherence of the toolkit went from 75% to 94%, which did demonstrate clinician adherence to the toolkit. And additionally, clinicians' perceived self-efficacy does have an influence on their own clinical decision-making in regards to pain management. So for my knowledge gap is that lack of structured OT-based KT toolkits. There is a lack of structured OT-based KT toolkits to enhance clinician perceived self-efficacy within cardiothoracic acute care, leading into my perceived problem that there may be a lack of standardized training for postoperative pain management, affecting perceived self-efficacy, potentially limiting functional outcomes for patients. So the purpose is that I want to develop the statement of purpose is that I do want to develop the OT-based KT toolkit to enhance their self-efficacy through the application of standardized KT techniques, contraindications, clinical safety, and clinical decision-making. My specific objectives is that I do want to obtain advanced skills in KT, including application safety, contraindications, and clinical reasoning of KT application, acquire direct patient experience with cardiothoracic population to inform the development of my toolkit, and also evaluate the changes in practitioners of the perceived self-efficacy through before and after measures. For my theoretical frameworks, I will be using the model of human occupation and the andragogy learning theory. The model of human occupation theory is an occupation-based theory which does entail the concepts of volition, habituation, and performance activity. Self-efficacy and volition do correlate with each other, which does influence how self-efficacy does play into the clinician's habits and how it affects their clinical decision making, being their performance capacity in regards to pain management. For andragogy learning theory, there are 5 aspects, being the problem-oriented learning, having experiential learning, being internally motivated, and having readiness to learn, and have self-directed learning, which are all aspects that do apply to adult learning. This is my PIO question, or just my question in general, being that does a structured OT-based KT toolkit improve the perceived self-efficacy of OT clinicians who have experience working with adults after cardiothoracic surgery? My methodology is that I will be adopting a quality improvement design, and for my evaluation and feedback methods, I will be utilizing a before and after questionnaire, being the general self-efficacy scale. I will acknowledge that it was quite difficult to find a KT-related self-efficacy scale for application, so I wanted to modify the GSES scale within the context of KT application and perceived self-efficacy for the clinician. Additionally, I will be using a participant feedback survey on a 5-point Likert scale through my in-service session to gain any feedback from my in-service. Our target population will be licensed acute care OTs at St. Rose Dominican Hospital who have provided direct patient care to cardiothoracic patients in the intensive care unit, intermediate care unit, or medical surgical unit. My participant selection strategies will consist of QR code flyers or word of mouth. Through the QR code flyers will lead to the general self-efficacy scale and also demographical information for the before measure of the general self-efficacy scale. My eligibility criteria will be full-time, part-time, or per diem licensed OT within the ICU, IMC, and MedSurg, who have worked with cardiothoracic patients, willing to participate in the KT educational session and complete the before and after questionnaires, and must be novice within kinesiotape. For ineligibility criteria, if they do have the inability to complete my educational session, procedures, and assessments, and if they do have tape allergies, skin conditions, or infections at the tape application site, or if the clinician is a KT certified clinician. For my plan and procedures, one thing that I do want to acknowledge is that for the recruitment process, I do know that it is in the implementation phase. I do plan on putting it within the planning phase to start recruiting as soon as possible come to that time. But regardless, I would like to conduct a needs assessment at the Capstone site, attain my KT certification, engage in observation, and also direct care with cardiothoracic patient population to inform the development of my OT-based KT toolkit, and develop and finalize my toolkit. And just as mentioned before, recruit the participants all throughout the planning process, and then administer the before measure within the QR code recruitment process. And then during the implementation phase, I will be delivering a KT toolkit education through 2 in-service sessions. The 2 in-service sessions will be 1 hour long. Will be 1 hour long. The first session will consist of just KT foundations, introduction to KT, clinical safety, contraindications, KT application within the context of cardiothoracic population, and also how they can use my toolkit as a reference for when they do work with cardiothoracic patients. And then for the second in-service session, spanning a 1 hour long, it will be in increments of 30 minutes. The first 30 minutes will be me demonstrating various KT applications, and then the next 30 minutes will be peer-to-peer practice for the clinicians. And then after that session is done, I will have them scan the QR code for the after measure. And then For the evaluation, engage in the descriptive analysis, prepare my manuscript presentation, and disseminate the findings and reflect on my capstone experience. So for ethical considerations, I must obtain IRB approval, maintain adherence to the ALT Code of Ethics, emphasize to the participants that this is voluntary participation. I will be giving them informed and verbal consent, and also that they do have the right to withdraw at any time. For data protection, I will be utilizing a two-step authentication process for participant data. And the anticipated benefits of the Capstone project is that there will be exposure to OT-based KT education through my toolkit, and there will be increased perceived self-efficacy regarding KT with cardiothoracic patients. Potential risks may be time burden, which can disrupt the clinician's workflow, but the proposed solution that I have is offering the in-service during their lunchtime or at a convenient time that best fits the clinicians. Additionally, they may feel discomfort from the general self-efficacy scale, being the before and after measures, but I will emphasize that these responses will not affect their work performance. Overall, I do want to develop this OT-based toolkit to improve the clinician's perceived self-efficacy for KT application within cardiothoracic acute care to increase their self-efficacy. Yes, to increase their self-efficacy, increase the utilization of the toolkit, and overall build stronger occupation-centered pain management within acute care. Thank you for listening to my presentation.